very honored to introduce our 2025 speaker, Dr. Jerry Gurwitz. Dr. Gurwitz spoke to about 100 people last night at a community lecture, and we are fortunate he is joining us today for Medicine Grand Rounds. And during that community lecture, we did recognize our Glennon Scholarship student scholars. Dr. Gurwitz is our Dr. John Myers Professor of Primary Care Medicine at the UMass Chan Medical School in Worcester, Massachusetts, where he served as the chief of the Division of Geriatric Medicine for over 20 years. Dr. Gurwitz has written extensively on improving the health and healthcare of older Americans with a special focus on medication safety. He attended Dartmouth College and the University of Massachusetts Medical School. He completed his internship and residency at UMass as well, and clinical fellowship at Harvard Medical School Division on Aging. He completed additional fellowships in research and leadership development for physicians at the Harvard School of Public Health. He has and continues to hold a number of leadership positions and has received many prestigious awards for research, education, and patient care. He has served on editorial boards for the Journal of the American Geriatric Society and also served as deputy editor and on the board for the Journal of Gerontologic Medical Sciences. He's authored over 350 papers, 100 plus editorials and book chapters, and serves on a host of regional and national committees in the fields of pharmacology, geriatrics and gerontology, internal medicine, research, patient safety, Alzheimer's disease prevention, and addressing the geriatrician shortage. Now, before Dr. Gurwitz joins us at the podium, I have a few housekeeping items. Just to remind us of our objectives today, I'm not going to read that to you. Dr. Gurwitz has ongoing financial relationship with United Healthcare, for whom he consults. The planning committee members have no relevant financial relationships with ineligible companies to disclose. All financial relationships have been mitigated. Today's presentation is eligible for CME through the Macon and Joan Brock Virginia Health Sciences at Old Dominion University. This presentation has been approved for one AMA PRA Category 1 credit. Now, before I turn the floor over to Dr. Gurwitz, I do want to recognize a special group of people we have here today. And if you could please stand, we do have the students from the medical and health specialty programs at Maury High School. So if you could please stand, this is our future. Thank you for joining us. And now, please join me in giving Dr. Jerry Gurwitz a warm and enthusiastic EVMS ODU welcome.
Can everybody hear me okay? Just make sure. And I'm thrilled to be here. This has been a wonderful visit and amazingly impressive. Love meeting with medical students. I am very intimidated by speaking to the future of this country. So thank you, all of you, for being here. And very curious what you'll think about my talk. So I'll just give you a little heads up about my talk. This talk is going to be sort of like hearing a talk about climate change. You know you should listen, but you don't really want to. So I'm just warning you about that. We're going to talk about we have met the aging and they are us. These are some of the things I'm going to be talking about today. Our biases and attitudes about aging, something called the demographic imperative, aging physiology and homeostasis, this term homeostasis, the bad things that can happen for an older person related to healthcare in their aging, making healthcare age friendlier. We'll talk about the failing geriatric medicine pipeline and how that might relate to you and the future of geriatric medicine. So I want to begin by talking about how most people think about aging. And what I'm going to do is present to you a case that was written by a physician named Paul Ruskin. And he published this case in JAMA. And here's what he wrote. She is a white female who appears her reported age. She neither speaks nor comprehends the spoken word. Sometimes she babbles on incoherently for hours on end. She's disoriented to person, place, and time. She shows complete disregard for her physical appearance. She makes no effort to assist in her own care. She must be fed, bathed, and clothed by others. And because she is incontinent of urine and stool, she must be changed and bathed often. She doesn't walk. Her sleep patterns are erratic. Often she awakens in the middle of the night, and her screaming awakens others. Most of the time, she is friendly and happy. However, several times a day, she gets quite agitated without apparent cause. Then she screams loudly until someone comes to comfort her. So when I describe this case of Dr. Ruskin, most of us have in our mind this image. However, it's just important to know that Dr. Ruskin was describing his baby daughter. And this is not Dr. Ruskin's baby daughter. This is my son, Sam, when he was an infant, and he's now 40 years old. So it's a long time ago. But I think it's important to understand that this is the picture of aging we all most fear. But the real truth is that even as we age, most of us never, ever envision growing old. So on July 11, 2021, I became an older adult. I turned 65, and in my own mind, I felt older. I'm not entirely sure why I felt this way. Maybe it was because I was eligible for something called Medicare. Maybe it was because I was taking more medications or was experiencing more health problems. But I began to feel older and considered myself among the population of older adults. So the question arises, when does old age begin? And if you ask a random sample of Americans, when a person is among those who are older in age, the average age indicated is 68. However, that average masks this age-driven variance in responses. The average, if you ask the same question of those under 30, they say their average is 60. So just keep in mind, that's the average. So many people under 30, including many of you, probably would say an old person has an age less than 60. But if you ask people who are 65 and older, what is the definition of being old age? The answer is 74. So perspectives on old age vary greatly depending on how old you are. So here's another question for all of you. How long do you want to live? And I'm pretty sure the answer for most everybody in this room is it depends. It may depend on your health, and if your health is failing, it may depend on your ability to continue to live in your own home, to live independently, to be able to drive, to be able to walk up a flight of stairs. It may depend on whether your cognition is failing, whether you're experiencing dementia. And I have to recognize that, at least in me, these things have a possibility of changing dramatically as I continue to age. And as I experiencing the aging process myself and everything that comes along with it, my perspective on how long I want to live may change. So let me tell you the story of somebody named Jean-Louise Calment. How many of you have heard of her? You can raise your hands. Okay. She was a French woman with the longest confirmed human lifespan. She lived 122 years and 164 days. She outlived her daughter and her grandson. She became internationally famous as the last living person to have met the artist Vincent van Gogh. And she described Vincent van Gogh as dirty, very ugly, ungracious, badly dressed, and disagreeable. In 1965, at age 90, she had no living heirs. She signed a deal to sell her apartment to her lawyer, who was 47 at that time. And her lawyer agreed to pay her to own the apartment 2,500 francs per month as long as she lived, which he did. He followed through, ending up paying for her apartment multiple times what it was actually worth. At age 85, she took up fencing. At age 100, she was still riding a bicycle. In 1985, she moved to a nursing home. She had lived on her own until she was 110. She was still in good shape and was able to walk until she fell and fractured her hip. And at age 114, she underwent a hip operation to repair it, and she became the oldest person in history to survive a hip operation. Okay, this is very important. She ate 2 pounds of chocolate every week. Here's some more stuff. She gave up smoking at the age of 117. And you know why she gave it up? She had difficulty seeing to light the cigarettes. One of her best known quotes was, "A kind God forgot me." Now, most of us in this room would say, wow, that's successful aging. That's amazing. But I want to tell you, in her final years at the nursing home called Les Maisons du Lac, she was essentially immobile. She was confined to her bed in a wheelchair. Her hearing continued to decline. She was virtually blind and had difficulty speaking. At times, it was not clear that she was fully aware of her surroundings. And at 122 years of age, 164 days, it was a very hot summer. She died alone in a nursing home bed. Only a very few people were allowed to attend her funeral, and all her relatives had died. So the question is, how long do you want to live? And that's not necessarily a very easy question to answer, right? Okay. Another question for you. Does anyone actually die of old age? When I was trained as a fellow, a specialist in geriatric medicine, one of the dogmas was, we don't blame anything on aging. We were taught that there was always going to be an identifiable cause for a new symptom or decline, as there may be reversible causes for that. In the United States, it is considered almost inappropriate to attribute death to old age. When I practiced medicine, I never in my entire career wrote on a death certificate, the person died of old age. When Queen Elizabeth died, Buckingham Palace did not provide a cause of death, interestingly. But in some countries, like Japan, there is less reluctance to attribute death to old age. And old age is listed as the third most common cause of death after cancer and heart disease. But it's not among the top 10 causes of death in the United States, which is interesting. Okay, it said that putting the name of a disease on a death certificate suggests that something was done to actually treat and care for a person. Death from old age, by contrast, suggests for us this unsettling inevitability. Okay, let's switch gears. I'm going to talk about the demographic imperative. That this lies behind everything I'm talking to you about today. We have been facing a huge increase in the number of older persons in the US. Some have called this the senior boom. Some have called this the silver tsunami. So how do I begin to talk about this? By the year 2030, the percentage of people in the US aged 60 and over will rise to 21%. So what does that mean? Okay, let me ask this question. How many of you have been to Florida? Raise your hands. Okay. If you've been to Florida, even if it's just a Disney World, you know there are a lot of old people in Florida, right? Right? 1 out of every 5 people in Florida is 65 and over. So what does that mean? That means by the year 2030, the entire United States will look like Florida, except older. Okay, today and every day, 10,000 Americans are turning age 65. In 2010, there were nearly 40 million Americans 65 and over. When I turned 65 in 2021, there were 55 million Americans 65 and older, and by 2035, there will be 70 million. Okay, in 2035, there will be more older people in America than people under 18. Imagine that. Why are there so many old people? Why are there so many old people? Okay, the biggest reason are people like me, the baby boomers. The baby boomers were born from 1946 to 1964. There were 80 million baby boomers. There are still 70 million of them alive. They started turning 65 on January 1, 2011. And as you realize, most are surviving long beyond age 65. And the most startling thing for me is the very first baby boomers are beginning to turn 80 next year, which is almost unimaginable. Okay, why is this important? And I'm looking at the young people in the room because what I'm going to talk about now is going to impact you and it's going to impact your children. So it's something called the dependency ratio. The 2030s are projected to be a transformative decade for the US population. Realize for the past 4 to 5 decades, there's been this huge baby boom population, and they've been primed for productivity. They've been working really hard. But now they've retired, they are retiring, or will retire over the coming years. So by the year 2035, there will be more, as I've said, people 65 and older than people under 18 who are aging into the working population. So why is this important? It's the dependency ratio. The dependency ratio is a measure of the number of retirees to working age adults. In the year 2000, there were more than 5 working age adults to support every retiree in the United States. By 2035, that number will drop to fewer than 3. There will be less than 3 working age adults to support every retiree. So those of you who will be working age adults, realize you're going to be supporting me, and there's going to be fewer of you, many fewer of you, to support people like me, and there's going to be many more of me. Okay, what about the oldest old? So this is a photograph of my grandparents, and that's actually a photograph of me. So that's a perfect exhibit of aging, okay? Look at me in that photo and look at me now. So both my grandfather and my grandmother lived well into their 80s. The fastest growing segment of the older population in the US are those 85 and older. When my grandfather died in 1981, there were only 2 million people in the US 85 and older. By 2010, that number grew to 5 million. By 2021 to 7 million. And by the year 2050, it will be 19 million of the oldest old. Okay, what do these demographic changes imply? Well, pick out any of your favorite chronic diseases. It could be dementia, osteoarthritis, balls and hip fractures, heart disease. The numbers of people with those conditions is going to increase exponentially over the coming years. The second thing we're worried about is multimorbidity. Multimorbidity is having 2 or more chronic conditions. Multimorbidity increases dramatically with advancing age. On the vertical axis is percentage of people with multimorbidity, and on the horizontal axis is age. And by the time people reach 85 years of age, over 85% have 2 or more chronic conditions, and most have many more than that. So here's another interesting situation. This is a picture that none of you recognize because it's the Jewish Home for the Aged in Worcester, Massachusetts. And this building is now condominiums, but when I was a teenager, I volunteered in this nursing home. And when I walked into the activities room of this nursing home, this is what I saw. Okay, what is interesting about this picture? You have to figure it out. And you can't say it's the hats. You can't say that everybody is white or Jewish. What's interesting about this picture?
One man.
There's only one man. There's only one man. A visit to almost any nursing home in this country will prompt the obvious question, where are all the men? Where the hell are they? Where'd they go? Okay, there are so many older women. If you look at the US population age 18 to 64, there are 100 women for every 100 men. 65 to 84, 119 women for every 100 men. 85 and older, 178 women for every 100 men. 90 and older, 333 women for every 100 men. just keep in mind this senior boom, this silver tsunami is really a phenomenon of women. It really is. And for those of you who are women, it's you. This is your situation. Okay, we're going to talk, now I'm going to switch gears and talk about aging physiology. One of my favorite quotes. The older people in the audience can understand this. The younger people, you have no clue, okay? The older I get, the better I used to be. I want you to remember that, okay? Okay, this is a picture. Does anybody know who this is? Anybody? Okay, if you were from Boston, you would know who this is. No. Although he's a pretty remarkable, successful ager. This is Johnny Kelly, famous marathon runner. Johnny Kelly died at the age of 97 in 2004. He ran 61 Boston marathons. He won twice and he finished second 7 times. And also he was married 4 times. Okay. If any of you are marathon runners, you sort of, one of your goals is to run the Boston Marathon. And in the Boston Marathon in Newton, Massachusetts, there's the beginning of this hill called the Heartbreak Hill. It's where it gets steeper. And that's where marathon runners quit because they're just so exhausted and all of a sudden there's Heartbreak Hill in front of them. At the bottom of Heartbreak Hill, there's this statue and it's called Forever Young. And it depicts a young Johnny Kelly at age 27 when he won his first Boston Marathon. And again at age 84 when he completed his final Boston Marathon, his 61st. And this statue it's really beautiful. I mean, it is really exemplifies aging. Compare the two, it's the same person, just in 2 different ages, at 2 different ages. So I was very curious about this guy. So I started looking up, okay, how did he perform in the Boston Marathon? And I plotted on a graph that you're seeing his performance from 1928 through 1991. And it's very interesting that notice the stability of the performance of this very premier athlete from his 20s through his 40s. But then notice something else, this slow progressive decline, such that when he ran his final Boston Marathon at age 84, it took him over 6 hours. Now that's pretty remarkable for somebody that age, but you can see this slow progressive decline in even this amazing athlete's performance. So my former mentor in geriatrics used to say, if you've seen one old person, you've seen one old person. And there's no one who embodies this more than Johnny Kelly, really. Just consider the contrast between Johnny Kelly at age 84 and his peers. Yet even in this premier individual, you see this dramatic decline and this evidence of aging, which is obviously inevitable. Okay, the experience of Johnny Kelly in running the Boston Marathon shows us the extent to which physical performance declines with advancing age. This figure brings it home. This figure graphs gait speed according to age on the horizontal and probability of living 10 more years on the vertical axis. The different colored lines indicate different gait speeds, with the green lines representing the fastest gait speeds and the red lines the slowest. Two things are apparent from this graph. Gait speeds decline with advancing age. The older you are, the slower you walk. But the graph also shows that within age groups, no matter how old you are, the faster you walk, the longer you're going to live. The faster you walk, the longer you're going to live. So I want you all to remember that. Okay. A decline in gait speed can be thought of as a proxy for decline in physiologic reserve. As we age, there is this progressive decline in physiologic reserve across essentially every organ system in our bodies. And this has been referred to as homeostenosis. Homeostenosis ultimately leads to increased vulnerability of adverse events happening, increased disability, increased dependency, and even death. For those of you in the audience, this decline actually begins around the age of 30, and it continues to be gradual and progressive. This decline varies person to person, varies widely. You know, Johnny Kelly, this decline is slower than me. Unfortunately, in the absence of any stressor, we do perfectly fine. But these declines obviously will take their toll. So here is a representation of that. Here is physiologic reserve on the vertical axis and age on the horizontal. When a younger person experiences a stressor, which is the red arrow, it might be a heat wave, it might be pneumonia, it might be an infection from COVID. There is more than enough physiologic reserve for homeostasis to be restored and for that person to recover. But in an older person, the limit of physiologic reserve can be exceeded, making it impossible to restore homeostasis. And that can result in decompensation, functional decline, disability, and even death. This very simplistic schematic captures what clinicians often refer to in their patients as frailty. And that's a state of depleted reserve resulting in increased vulnerability to different stressors. Now, all of us remember the pandemic. This decline in physiologic reserve was very apparent during the pandemic. And this is information coming out of Italy and China in March of 2020. If you look at the green bar and you look at the red bars, you will see this dramatic increase in death rates among those 60 and over, 70 and older, and 80 and older. And that was directly related to everything I just told you about this decline in physiologic reserve. That's why older people were dying at such high rates. Okay. Let's talk about making healthcare and healthcare systems better and easier for older people. We want to make it better. We want to make it safer. How can we make it age friendlier? And according to the Institute for Healthcare Improvement, healthcare system is age friendly when it is designed to coordinate all our care as we age, while also making sure our personal needs, our values, and our preferences are at the center of that care. So very quickly, I'm going to share with you something called the 5 M's. And the 5 M's comprise the essentials of geriatrics. They're a framework for training healthcare professionals and for changing our healthcare systems. Okay, the first M is mind. And that M focuses on cognition, dementia, reducing the risk of delirium, and addressing depression. The second M is mobility. That includes addressing functional decline, gait and balance, and fall injury prevention. The third M is medications. We need to optimize prescribing practices, de-prescribe medications that older people don't need. Doctors and other healthcare providers continue to add medications onto these complex regimens for older patients. And we have to prevent drug-related harms and adverse drug events. The fourth M is matters most. It's aligning healthcare goals with a person's individual preferences. We have to recognize that every person is different. Every person has different goals and preferences for their health. And the final M is multi-complexity. It acknowledges that in an old person, it is inappropriate to consider a single medical condition to the exclusion of others. And frankly, it's much easier as a healthcare provider, as a physician, to just focus on one thing, to just focus on the heart, to just focus on the lungs. But an older person with multiple chronic conditions, that is totally inappropriate. So every year at UMass Chan Medical School, we do what we're doing today. We invite a well-known geriatrician to come speak to our medical students and residents. And one year, the honored guest gave a talk on the top 10 reasons for going into geriatric medicine. He talked about the challenges and complexity of geriatric medicine. He talked about how grateful older patients are for the care we provide. He's talked about how geriatricians are more satisfied and happier than people who choose other professions in medicine. But the top reason, he said, for going into geriatric medicine was because nobody else wants to. So that's what I want to talk a little bit about, this failing geriatrics workforce, this failing geriatrics pipeline. We need a 50% increase in geriatricians and geriatrics nurse practitioners and geriatrics providers by the year 2030. And that is, I'm just telling you, it's never going to happen. So I'm going to share with you a quote from a book that I highly recommend to almost everybody called Elderhood. This was written by Louise Aronson. And this was a finalist for a Pulitzer Prize. And she describes something that I've experienced countless times in my career. So I'm going to read from what she wrote. When I tell someone what I do for a living, they usually have one of two reactions. Either their face contorts as if they've just smelled something foul, or they offer compliments to me about my selfless dedication to an important cause. Those in the former camp usually hurriedly change the subject. Many in the latter group tell me, either outright or by implication via excessive praise and admiration, that I'm a saint. These apparently opposite responses are actually the same. Both imply that what I'm doing is something no one in their right mind would ever do. So let me show you our problem. In 2025, in a medicine, after you finish residency, you match for specialties. You go into a match. Whether you want to go into cardiology, oncology. So in 2025, this current year, last year, there were 382 positions in geriatrics offered nationally. Only 169 of those positions filled. That's 44%. 213 positions did not match. Okay, compare that with cardiology. They matched 99.8% of their positions. Hematology oncology, 99.7%. Neurology, 99.2%. So interestingly, I told this story a couple of times since I've been here. A couple of years ago, I was hiking with my son, Ethan, who's an antitrust lawyer. Never cared at all about what I do, didn't care at all about medicine, never ever talked to me about what I did for a living. So, any of you have hiked in New Hampshire before? Okay, so you know the trails in New Hampshire. They're rocky, they're steep. So he's always wondering, why can't you keep up with me, Dad? You know, he thinks I'm so slow. I try to explain to him I'm aging. You get slower as you get older. So he believes that if he engages me in conversation, he'll distract me enough that I'll start hiking faster, which is not true, by the way. It doesn't make me hike faster. But one day he tried to distract me by asking me about what I did. And I started explaining to him about geriatrics. And I talked to him about the geriatric imperative. I told him about the aging baby boomers, but how it's never been a popular field. And how I told him that the field was never perceived as prestigious as other fields. And he said, well, what are the prestigious fields? And I said, like dermatology, orthopedics, cardiology. And I told them that in the mind of medical students and residents, prestige and compensation are directly related to a large extent. But I also told them that's not everything, because my father was a pediatrician, so his grandfather was a pediatrician. Pediatricians don't get paid that much. They're on the lower end of the pay scale for physicians. But interestingly, pediatric residency spots fill. Over 90% of pediatric residency spots fill. So there's something beyond money that influences how people think about this career, taking care of older people. And I said a big part of this relates to biases, ageism, and societal attitudes about aging. And at the end of this talk that I was giving him as I'm struggling up this mountain, he said two things to me. He said, one, Dad, have you ever thought that maybe you're the problem? That you and your colleagues haven't proven the value of geriatrics to people? Then the second thing is, he said, you know, what you told me is really interesting and you really should write about this. So I was taken back by his first comment, but I did end up writing about this. And this article is published in the Journal of the American Medical Association in 2023, The Paradoxical Decline of Geriatric Medicine as a Profession. And interestingly, I received a lot of criticism for writing this article from my colleagues in the field, especially from the leadership. But I received many messages of support. And here's a message that I received from a geriatrician named Anthony Caprio, who to this day I've never met. Somebody in this room knows him. But he wrote me this message. He said, I believe you have captured that collective sense of frustration about geriatric medicine, at least among middle to late career geriatricians. Since I was a fellow 20 years ago, I've always had the sense that geriatric medicine was just on the verge of greatness. Certainly the realization of what we do and how we can benefit patients, our healthcare systems, our society would eventually be realized. and we would be given the support and resources that we really need. 2 decades later, I'm much less optimistic. I'm skeptical that I will see this tipping point happen during my career. I also worry whether there will be geriatricians to care for me when I need one. It is difficult to convey optimism to my faculty and my fellows and my fellowship candidates. However, I appreciate your statement. Geriatricians will never stop advocating for better care for our aging population and the need for physicians with expertise in caring for older adults. I believe that is true, and it speaks volumes about our profession. If only there were more of us. And there are people going into geriatrics. These are a few people who have completed geriatric residency and geriatric training, who came out of our medical school. And this is the future, and this gives me hope. So I'm just going to finish with one more quote from Dr. Aronson. She writes, "If you made the choice to be a geriatrician, you are doing it for all the reasons that give life meaning. It interests and inspires you. You believe in it, and it gives you pleasure." And I've never regretted a day having made the choice to become a geriatrician. So the final thing I'll say is, she also writes in her book about the recipe for successful aging. So I'm going to quote her again, because people often ask me, what's the secret of successful aging? And she says it relates to 4 things. Number 1, good genes. Number 2, a good enough amount of money. Number 3, good luck. And number 4, for you young people, probably the most important is having at least one really good kid, preferably a daughter. So with that, I'm going to end, and thank you for your attention today. Thank you. Any questions or comments? And yeah.
Thank you for the second presentation as well as your first last night. As far as successful aging is concerned, could you comment on the recently released Pointer study, which effectively replicated the Finger study that was 10 years before? And to many of us, the Finger study was totally underappreciated. But now the Pointer study shows multi-domain lifestyle changes: nutrition, physical exercise, mostly walking, cognitive exercise, and among other things, social engagement, modified risk for those at risk for dementia. Could you comment on successful brain injury in aging from the perspective of the Pointer study?
Yeah, Paul, right? Thank you for bringing up that point. That's an incredibly important point. A lot of people believe that new medical technologies or new medications or innovations in whatever are sort of the answer to being able to age well. And what we're learning is it's these lifestyle changes that are most important. And one important thing that I've tried to drill into myself is exercise. Some have called exercise the fountain of youth. Exercise positively influences cancer outcomes, prevention of dementia and cognitive loss, cardiovascular disease. It is really amazing. If you look at interventions that include exercise, the outcomes are better than these high-tech interventions or these new medications. So that's the one point I'd say. Thank you for bringing that up. And those are the things that are most important. And those are the most important things to do, to begin doing when you're young. It's important to do them when you're my age, but it's very important to do them when you're young. Millie.
Thank you so much for that presentation. You had a beautiful slide on homeostenosis and the physiologic principle. I'd be curious when we're talking to patients, how you describe that to patients and families in a way that they can grasp it and understand it. After decades of practice, are there scripts or things that you find resonate more with patients or their families? It's not uncommon for us to hear mom, dad was fine until blank. And so the preface to future goals of care conversations often is this description of homeostenosis. And so I'd be curious how you approach that conversation.
Yeah. So that's an interesting point, and I have to confess, I've never done that. And I think maybe I should have, but I've been nervous about it because I always worry, will I get too jargony or medicalize things and not be a good explainer to people, to families and patients. However, I've given this talk multiple times to different types of audiences, and I give the exact same talk. And the lay audiences, they understand it as well as all of you do. They get it. And I'm always sort of surprised. I'm worried about those slides. Will they get it? Will they understand those arrows and this physiologic reserve thing? But I think a lot of us as healthcare providers often go to very medical scientific explanations for things when it's a crisis situation. And I'm always worried that will they fully grasp, or am I using that as a crutch when I should be trying to understand how they're feeling more than explaining exactly to them exactly what is going on and why 2 weeks ago they were fine and today they're in an ICU near death. So, but you've given me something to think about.
Over 40 years ago at Hopkins, as part of internal medicine residencies, John Burton had each of us each week see 3 patients at home, because each old patient at home, what you've seen one old patient at home. With the time and money constraints to set today, do you see some benefit for students and residents at least having that small experience, what they may benefit and learn from that?
Yeah, thank you for that question. I think that's a fantastic experience for anybody, frankly. Physicians in practice, definitely in primary care, barely have time to brush their teeth in the morning. So the idea of doing that is very hard, but you can learn so much from that home visit. You can learn so much from just opening a person's refrigerator or looking at their medicine cabinet if they'll let you, or having them show you their medications. There's so much to be learned from that, and you are the risk of falls. I mean, what a disaster falls are. It's a huge risk of death in older people. And I think if a medical student or resident is going with somebody who has some training or insight, that's more important than just sending them in on their own to figure it out. But I think that's a remarkable thing to do. The other thing is the home as a setting for care and hospital at home programs. I think those can be pretty remarkable, although they're not being funded at this time by the federal government. And also, we've been doing some stuff on skilled nursing at home, post-hospitalization. So a person wants to be in their own home. It's interesting when you bring the healthcare setting into their own home, the things you can do. that make it better for them, lower cost, and you can also deal with preemptively some of the risks that exist in their home. So thank you for that question. Yeah.